Welcome back. Today I'm sitting down with Howard Catton, CEO of the International Council of Nurses, or ICN. I've been eager to have Howard on the podcast because when I first took this job at CGFNS, I attended a strategy retreat with our board of trustees where Howard was a guest speaker. He spent an hour giving all of us a comprehensive update on the global state of nursing, and let me tell you, I couldn't take notes fast enough. Howard is a nurse with broad global experience in clinical practice and nursing leadership in England, New Zealand, and the United States. For 10 years, he was head of policy and international affairs at the Royal College of Nursing in the UK and has held many impactful positions in both clinical practice, education, and government. He's been with ICN since 2016 and in the CEO seat since 2019. He is passionate about the impactful and critical role of nurses in sustaining, elevating, and evolving global care delivery, and he's possibly the most knowledgeable person to speak to what's truly shaping and impacting this profession globally than anyone I've ever encountered. This episode is a little longer than most of our episodes, but honestly, the data and insights Howard shares here today are just too good to cut short. So pull up a seat and settle in. There's a lot of information packed into this episode, so here we go. Across global health systems, health workers on the front lines of care delivery are carrying more on their shoulders today than ever before. Workforce shortages are increasing. Scope of practice is shifting, and skill sets are definitely evolving. In this podcast, we're setting the table for some powerful discussions with nurses, allied health professionals, regulators, tech innovators, and other thought leaders across the globe. Together, we're diving deep on the challenges and opportunities that loom large for recruiting, training, and equipping the health worker of the future. Welcome to Care Anywhere, the Global Health Workforce Podcast, brought to you by CGFNS International. Hi, everybody. Welcome back to the podcast. So excited about this episode and welcoming my guest today, Howard Catton with ICN. Howard, it's so great to have you on the podcast. Welcome. Can you kick us off? Tell us a little bit about you, your background, and the nature of the work that you do with the International Council of Nurses.
Yeah, hi, Lea. It's great to be with you. I'm a nurse, of course, and you can probably tell by my accent. I was educated in the UK and spent quite a lot of time in the UK. I worked for the National Health Service, some other healthcare providers, spent a bit of time in health service management, but then I had the opportunity to go and work as a nurse in other countries, a bit in the US, a little bit in Australia as well. But from a very early part of my career, I was very involved with my National Nursing Association and ended up being on staff for the Royal College of Nursing in the UK. And immediately before I came to ICN, I was responsible for policy, political, international affairs at the Royal College. When I first came to ICN, I was in charge of the nursing portfolio, and just before the pandemic, perfect timing, took on the role as the CEO. I think people know ICN is the internationally recognized body by WHO and the UN to speak on behalf of the nursing profession. There are now over 28 million nurses worldwide, but our membership on national nursing associations, we've got more than 130. Some of our national nursing associations have very much a professional practice focus. Some will have more of a working conditions, trade union focus. Some, in fact, are regulators. Some have a combination of roles as well. WHO is a key organisation for us to work with. I'm speaking to you from Geneva in Switzerland, where we're headquartered, but we work with the whole of the UN system and other international bodies and agencies as well.
It was great to hear you mention associations. We could probably talk about that for a bit. Not only your own experience working your way up professional development through associations, but the power of associations that are now gathered collectively as members with ICN. I know on my side of healthcare, I wouldn't be where I am today if I hadn't plugged into my professional association. So I always love to hear that. And, for our nursing audience as well and health workers who tune in, how important it is to get connected for professional development and to have a share of voice and influence at the table. So that's a great way to start us out. Let's focus on what ICN's work really is focused on, which is across a number of initiatives, of course. Global nurse workforce issues, challenges, and development across a broad spectrum. But let's start with the status check. When I took a look at your 2022 Sustain and Retain and then the 2023 Recover to Rebuild reports, there's just so much data in there about the current state of the global nursing workforce, some projections for the future, some calls to action for all stakeholders when considering what needs to take place to support development and growth and career opportunity and advancement for nurses. One of the things that sticks out in that report is the estimate that there could be a need to replace up to 13 million nurses globally in the coming years. That's a significant number. Is this still an accurate projection from your 2023 report? What's contributing to that shortage, burnout, and turnover, and why is it continuing to increase? It's probably a good place to start and lay the landscape for the discussion.
So I'll try not to overdo it on the numbers front, but I think most people will be aware that we had the first ever State of the World's Nursing report published in 2020. We worked with WHO on that. It said that there was a shortage globally of almost 6 million nurses. But the data for that report was based on reports and data collection that preceded the pandemic. Some of it may have been 2016, 2017. Most of it was 2018, 2019. We were then hit with the pandemic. We, as you've seen, we reported extensively from ICN on the impact of the pandemic on the global nursing workforce, infection rates, tragically and very sadly, thousands of deaths, but also issues about mental health, disruption to education, changes to the way in which nurses were being allocated to work as well, issues around nursing leadership. I think people are very familiar with seeing the chief scientists and the chief medical officers popping up on their TV screens, perhaps not so much the chief nursing officer. So when we looked at that impact, we termed it the COVID effect as a catch-all for those different things that we were seeing happening. And we said what we're really worried about, that this could drive an increase in nurses leaving earlier than they otherwise planned to or would have done. And I worked with Professor James Buchan, a very renowned global nursing workforce expert, to look at what the impact of that could be. And we thought this could add 2 or 3 million to the shortage figure. And you'll have seen there have been numbers of reports that have looked at increased sickness, burnout, and attrition rates as well. On top of that, we know that globally the nursing workforce is aging, not aging at the same rate all around the world. There are some parts of the world where nurses have a much younger age profile, but overall, globally, we did some work. We did work with CGFNS to look at this issue as well, and said we could be looking at another 4.5 to 5 million nurses who will retire over the next 4 to 5 years. So we've got a 6 million shortage, we've got 4 or 5 million due to retire, we've got a COVID effect. So that's where it gets us, Leah, to a figure of 12 or 13 as to what it could be. But we don't have the most up-to-date data, and it's one of the reasons why we lobbied very hard from ICN to say to WHO, we need another State of the World's Nursing report. As I said, I'm a Brit, and we have this saying in England that you can wait forever for a bus to come to take you to where you want to go, and then all of a sudden 2 or 3 come along in 5 minutes of each other. We waited 75 years for the first State of the World's Nursing report, but we're going to have the next one next year. So we'll have only had to have waited 5 years, but why that's so important is that we are right now have been collecting the data, which will include data about what was happening over the course of the pandemic. So that impact of the COVID effect we'll be able to see. But I expect that we will also see places where we've seen an increase in numbers of nurses, where the population has grown, because we know that there are countries who have been investing in pre-reg education to grow their nursing workforce. So what our final shortage number will look like, we'll wait and see. There'll be a number of dynamics that I think are taking place. But I make this point as well. If you're playing the numbers game, not that I want to play the numbers game on this, but it's another important part of the analysis, because there were some academics from the University of Washington who said, let's look at global healthcare needs, aging populations, NCDs, all of those things as well. They did some work to say if the world increased its ambition for meeting all of those needs, they actually came up with a figure of we could need 30 million nurses. So it depends.
If we were doing it right, basically.
If we set a really high, high bar, it could be. There is no doubt that we have a global shortage of nurses. And at ICN, one of the things I think we want to make sure that we do is that when we're quantifying and saying what that global shortage of nurses are, that we absolutely do take consideration of what future healthcare needs are, because we know when there are too few nurses, the outcomes for patients, trips and falls, medication errors, failure to rescue, ultimately mortality, all of those things go up. And there's also some really interesting work now that tells us much more probably than we knew before about if you're short-staffed, you have to make prioritization decisions, and seeing what nurses prioritize and what they don't is significant in terms of it may be that the time to talk to a patient, to help them to self-manage, to give them health prevention, health education advice, to have care conferences, to talk to the multidisciplinary team about somebody's condition. These are the sorts of things which the evidence is saying when time is short, those are the things that get missed. And that's really important for us to understand as well, because its impact not just on the quality and safety of patient care, but those things that have missed, I think, also cost us more in the longer term. And I'm sure that you may want to.
Well, and that note about keeping an eye on the future, it brings to mind that's tied to other critical issues that are being advanced globally. If we're able to move the needle on universal health coverage, for example, globally, that's going to increase the demand for, care providers. I know it's certainly an opportunity for advanced practice nurses who have a widening scope of practice will be, very much at the front line of the push for primary care at minimum for universal health coverage. So that's compelling that in order to look at that number, you really have to look at not just the current shortage, but the future needs, because it's certainly tied to some of those other initiatives that you're promoting. And I appreciate that. Coming out of the pandemic, we've seen not only, and you mentioned it before, an increase in burnout and turnover, which I think everyone has certainly reported on. I think I've heard it in every conference I've been in for the last couple of years, but also just a slow response to policy change to address some of the issues that are driving that. Some of that turnover is nurses that are moving out into, leaving bedside care, frontline care, moving into other tech roles, informatics. So certainly it's not necessarily a replacement, but a displacement. How is the ICN action agenda focused on protecting and supporting nurse workforce development at the same time that global health systems are recovering from the pandemic and grappling with shortage? Because it seems like a bit of a catch-22. Some of that overburden and burnout, it really is being caused by workforce overload. So you've got health systems that are grappling with that, and then at the same time, the calls to action to really address what the impact is. I know you guys call for, impact assessments, both at a government level and a healthcare organizational level. How can those two things happen concurrently, I guess, is what I'm asking.
So if we go back to the State of the World's Nursing report, as important as it wasn't the end point. The State of the World's Nursing report provided us with the data from which we then built the strategic directions for nursing and midwifery, the current global nursing strategy. And that at its heart has actually got four very simple asks in terms of investing in decent jobs, in leadership, in education, in service delivery. ICN particularly pushed for the service delivery pillar of that strategy because that's the piece around you look at the future health agenda. I often say this when I share with people what the future health agenda, global health agenda looks like. I say, you see the future global health, what I see is nursing work. All of this stuff, to get all of this stuff done, these care needs met, you need nurses to do it. But we also have nurses with new solutions, whether it's through advanced practice roles, maybe first contact, it may be chronic condition management. There may be nurse-led models of care, which are taking pressure off acute systems. It may be prevention. We've got all of these solutions as well that we can bring. But often people can be skeptical. Our medical colleagues love them to death, but they can be skeptical about advanced nursing roles. Health systems may not fund and invest in a nurse-led model of care. So there's a whole pile of work that we need to do on that. But there is also the points that you're raising around the fundamentals of decent work. I much prefer, and I try in a lot of when I talk about this issue and when ICN are highlighting this, to say, let's not talk about recruitment and retention, let's talk retention and recruitment, because what we've learned from the pandemic, but what we've learned from the pandemic hasn't just come from the pandemic. This is the result of a lot of historical underfunding and lack of recognition and support for decent work. Again, without being flippant, one of my tests for if I go to a healthcare facility to meet the staff is to see what the changing rooms or their staff room look like and what their canteen and what the food is. And it's shocking. You can't, you're working 12-hour shifts, a long row of shifts. We know this, and you can't get a decent meal. You might not have somewhere, pleasant to get changed or to take a break. That's before we even get started on things like car parking and childcare or dependency leave as well. None of this is rocket science. These are fundamental things that everybody in all other sectors expect to get as part of a package and of decent work. And we've fallen far too short in many, many parts of the world to deliver that for nurses. And that's why one of the things that, as well as the global strategy, WHO, last year on International Nurses Day, we put out a charter for change, simple 10-point plan about what you need to do to support decent work, retention and recruitment as well. There's issues around leadership in that and advanced practice as well, but it's a simple 10-point plan. So what we've been trying to advocate are solutions which are real, which we know work, that leave people in no doubt about what needs to be done. So nobody's saying, oh, we've got this global nursing shortage, what do we do with it? Well, here is the stuff, here are the things that you need to do that resonate with people at the front line. We can be very good. It's important to have some of these policy discussions, and we need to be involved in that arena for sure, but we need to be relevant to the needs of every one of the 28, 29 million nurses who are working around the world. So that's where a lot of our focus and the Charter for Change comes from as well. as I said, we're now just in the process of working on the next State of the World's Nursing report. That will be launched. Plan is to launch it first quarter of 2025. It will be on the agenda at next year's World Health Assembly with a discussion about what happens to the global strategy for nursing, which we're working to see an extension to the current global strategy on nursing as well. So that then gives us, this the profession has had a global spotlight from 2020 for all the reasons that we've discussed, but we're also trying to set a clear global path for the next 3 or 4 years as well. And the importance of doing that at WHA is to get political consensus and buy-in as well. So those strategies are discussed, voted on and agreed by country delegations, which include health ministers and others as well. So they've signed up to them here in the wonderful setting of Geneva in Switzerland, but our associations can get hold of those people, have the meeting with their political and policy leaders back in country and say, fabulous that you said these really positive things and you gave your vote to nursing globally. What are we going to do now to translate that into action here in a national context?
Global action and investment has been a strong call to action for ICN across all of these initiatives. I'm assuming that will be the same coming out of this report next year. What investment and action would you be calling governments to take? Certainly there's calls to action and investment and impact assessments that you would be recommending for organizations and health systems. But what about the government level? What can governments do if they come out of this? These delegations come out of the General Assembly next year, and they're taking this back to at the organizational level. What changes need to happen at that level so that can facilitate at an organization-wide perspective that rollout of some of those changes?
So the theme for this year's International Nurses Day, we chose, the board selected, has been the economic power of care, to bring into really sharp focus the need for investment, which, as you say, you're right, it's been there for a while for us. But why did we bring it into particular focus this year? My observation, my reflection on my time at ICN and the advocacy work that we've done, there's been some fabulous work that our associations have brought forward and that we've used to show and demonstrate the health benefits and the health outcomes of investing in nursing. That's not only, of course, that's the right thing to do in terms of the rights of individual nurses, but it's more than that. This is about improving people and population health. And I think associations and ICN have pushed that evidence, brought that evidence forward really very, 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 very strongly. But it hasn't made the sort of breakthrough in terms of investment that we would have wanted it to. And you're scratching your head to think, well, why won't you invest where you can save lives and you can improve people's health? And the answer to that question a lot of the time is people who say, look, no, we get it, Howard, we get it, ICN, we get it, Dr. Cipriano, but times are tough economically. Pandemic cost us millions. We've got cost of living increases. We've got energy rises. There are, politics, as we all know, is about the choice. We've got choice and we've got trade-offs, and we can't do as much as we'd want to do for nursing and for health. And that's why we're trying to this year to bring forward evidence to say we think that there is as persuasive evidence base, an argument for the economic power of care, for the economic benefits of investing in nursing, as there is from all of these health benefits as well. So the report this year, freely available on our website, work that it's not just ICN work. We've got well-known economists and people like the OECD who've helped highlight the massive costs of ill health. It's estimated something like 15% of GDP could cost about that amount, the costs of ill health
It's higher in
the
the
world.
U.S. that GDP spend now.
So so,
I think
so
it's upwards of 17 or 18% now. Our GDP spend on health.
it's
So yeah,
eye-watering. Huge numbers. So that's the cost of ill health. What about if I put my dollar into health care? What's my return on investment? And again, the report shows that you're going to at least get a dollar for dollar return. You're going to double your money. You're going to at least get $2 return on one. In low middle income countries, it shows that it's even higher than that. You also see the costs of on the nursing workforce of sickness, of attrition, international recruitment. The turnover and sickness costs our health systems significant amounts of money. To replace somebody who leaves, it can be 40,000. Those numbers are in there. And then on top of all of that, if you then you make that investment and you look forward, though this sounds a blindingly obvious point to make, we are providing a healthy population that can work, that can be productive, that can drive our economies as well. And we know that in many parts of the world, economies are struggling as a result of access to supply of labour, supply of high quality labour as well. We know how dependent in parts of the world we are on a more experienced, skilled workers as well, who we want to keep in the workforce and using them. And this applies as much to nursing as well for bringing through the next generations as well. So when we look at all of those issues, we say, here's a health argument for investing in nursing, and here is an economic argument as well. And if that isn't enough, the other thing that we know is that we will be overwhelmingly investing in women and addressing deep historical inequalities and discrimination. We are also see very clearly the relationship between ill health and poverty, and ill health and conflict and breakdown of societies as well. And there's over the last few months, the last 2 years, our work in response to global conflicts, our humanitarian work has really grown. It's become, people often talk about the pillars of ICN being regulation, education, working practice issues and professional practice, and they are absolutely, but we've seen this focus on a humanitarian response become as important as a pillar of the work that we're doing as well. So now all of those, you put all of those together, that seems to me to make a really, really strong and convincing case to help politicians to make the right choice to invest in nursing and to
you
invest
wouldn't
in
think
health.
you'd have to explain all of that, the tie between wellness and sustained employment and lowered debt. And the impact on the economy, but you're right. When it comes to election time, there's a lot of political issues on the tables, and healthcare is just one of many. So it's probably a drum you have to keep beating with the right people for a long time. Do you see some encouraging examples of where this is happening now, where governments and organizations are investing well, and we're seeing some of that turn around?
I may not go as far as say it's turning around, but there are absolutely encouraging signs. We know that there are parts of the world who have invested in nursing education to educate more. We've seen in a response to strikes and disputes, which again became much more prevalent after COVID. But again, and I make this point that they weren't just in a response to COVID. COVID was straw that broke the camel's back, but there was a culmination of a lot of other historical issues as well. And I think you saw in many countries how patient safety had come much to the fore in terms of the arguments and the advocacy that people were making. We just had a big success in Korea in the last few weeks, where they have enacted a piece of legislation, a nursing act, a nursing law. That's taken 5 years. That's taken a huge effort by the Korean Nurses Association. Dr. Cipriano, myself, visited a few times. coming out of their Parliament building and seeing thousands of nurses in front of their Parliament building, lobbying, campaigning, and asking for it. These things take, this is where the importance of national nursing associations and the importance of advocacy and of mobilisation as well. So there are signs of progress, but I think at a government level, what I'm particularly there's some signs that I'm encouraged about as well, with governments also recognising that it's not just the health ministry that's the responsible department for getting this stuff done. Part of this making the argument for health is about showing our political leaders how here's your health minister, but he's talking to your communities minister, and maybe talking to your prison minister, and is talking to your housing ministers as well, and how they then very quickly see how somebody who is in a health crisis, whether that's physical or mental health, loses their job, spirals into perhaps addiction or drug use, becomes malnourished, may develop chronic physical conditions as well, might then become an issue in terms of safety, security within communities for people who are desperate for money or for food as well. And there are really good examples of nurses who are, there's social determinants of health, of course, that we all know as well. But nurses who are working to join those up, to go to root causes, to focus on prevention. But when you have health ministries coming together and saying with the others and saying we'll take to one health approach across governments, then look, invest. Health ministers saying invest in me for the workforce to do X, Y, and Z. But I believe that you'll see dividends in terms of pressures on your housing budget, your social security budget, improvements in labour suppliers as well. Now, these can sound, and I know this because it's on the one hand, because a lot of what we're talking about here is it's again not rocket science, simple, straightforward stuff. But it might seem a little bit distant and removed for nurses to be making these arguments. And I'd have people who sometimes look at me and think, hang on, it's just ICN talking about issues to do with global peace and global economics, sometimes with climate change. We had in the early days of climate change. But when you look at what nurses do and you join the simple dots between how they identify care, how they go through a health assessment to put a plan together, to implement it, to evaluate it, you very quickly see how nurses' practice takes them into all of these other domains, which is why we are absolutely a legitimate voice in these much bigger policy and political debates. And I think we've been missing. The voice has been, we know this, people have, and we've heard forever, give me a seat at the table, give me the seat at the table. That's been a really important rallying call. It's been a really important rallying call, and I wouldn't want to underestimate that at all. But we have to take it to a different level of dialogue to make these connections. And critically, when we do get those seats, that we make a positive and powerful impact, that other people sit around and think, wow, I was missing out on that. And that's a really important point. And I need to think about that in terms of the solution that we put together. Because if we get the seat at the table, but then we're ineffective or we're quiet, we actually set ourselves back.
I was going to say not just a seat at a table, but a leadership seat at the table, right? It's one thing to have a chair at the end of the table. It's another thing to actually be at the leadership space, which you see increasingly nurses moving into, which is so powerful and I think transformative for the future of healthcare, because those that are closest to the patient, to their social determinants of health, who have the ability to look at the entire ecosystem that patient is thriving or not thriving in, really, I think, have the greatest perspective on what needs to change. So kudos to ICN for really leading that for so long, that voice for nurses. So let's talk a little bit about education and training, because some of this shortage, some of these challenges, I'm assuming some of what would come out of this nursing report next year will have to touch on recruitment, training, graduation rates. How do we address challenges in those things, recruitment and training, and how do we address the paradox that sometimes the graduation rate is sufficient? That's not the challenge of getting nurses into nursing school, but maybe there are other economic factors that are keeping very qualified nurses either unemployed or underemployed. We hear a lot of times at CGFNS of nurses that are, obviously having to move from one location to another to seek opportunity, but are not able to work at the top of their licensure. Many times are not able to find, jobs, or they are underemployed in the roles that they're in. How will some of this investment and call to action that you're baking in to these recommendations really focus on what changes might need to be made at a recruitment and training level for nurses moving forward?
One of the challenges that we've been very conscious of at ICN, the work that we've been doing, is that when you reflect back some of the reality of what you see happening and going on around the world, the issues that we've been talking around as well, there is, we do worry that is not the recruiting call to the profession that you want it to be. That doesn't necessarily grab people and say, I want to be a nurse. I've never lost my belief that it's the best profession in the world, and we need the opportunities that it gives you to make a difference, the avenues that you can go down, the change you can make to real people's lives. If you want meaning and to make change and difference and to improve, then nursing is absolutely there. But we're making it tough for people. There's some recent OECD data which shows for the majority of OECD countries, the interest amongst 16-year-olds in going into the nursing profession is on the decline. Now, there's a whole pile of factors that are at play there. But if we start to unpick it, sometimes I think we make it really financially difficult for people to go into nursing. Tuition costs, the fact that you can't easily get part-time work whilst you're a student because you're on placement, you've got your studies to do,
clinical
and
rotations, all those things.
Exactly,
Yes.
and you're exhausted. You're exhausted at the end of the day. You make it through all of that, and you can then find that it's a struggle to get a job. You may have to travel or move, because we have to travel and move, but it may be really difficult to get a job. You may not be able to get a job in the area you want it. You perhaps am I going to get the mentorship and the support in those early few months, in those first couple of years when I'm making that transition? And then if I want to move and progress, there are a number of health systems around the world which I think trap people at entry level in a way, or close to entry level in a way which again would be just unacceptable, and in other sectors. Nurses need to be able to see a clear career path and trajectory, and to see the support, the development, the encouragement which is going to take them to that place, and to be able to see the role models and the leaders who have gone before, and who give confidence that it's doable, and that we've got great faculty to support people through all of this. And we have got great faculty, but they are under huge pressure and strain, and in many parts of the world, are aging as well. So it's again, a lot of this is not complicated stuff that we need that we need to be looking at. I think there's often a lack, or there could be more imagination about how we do some of these things as well. If you're struggling to get people in, or to hold them in as well, if we were a big other industry, if we were Microsoft or Ford or whoever, we'd look at how we we incentivized people. We would say, look, if you stay with us, here are financial incentives to stay with us. Here is support to do education and training. Here's time out opportunities. Here's a package of things that we could do to help you look after your family and to get some dependency leave as well. It's pay is important, and again, be careful how I say this because I don't want to underplay the importance of pay, but there are a pile of other factors which actually can be more magnetic in terms of holding people into their work if they feel that they are valued, respected, and looked after. Part of that is really believing that your voice in healthcare is heard and matters, and that within the system, the hospital, the clinic, wherever you work within the clinical governance system, but actually it means I want to hear what practitioners have to say. I want to listen, I want to learn, and I will respond and react and change things according to that as well. So there are a pile of things there which I think that health systems should focus and should concentrate on as well. On the pay issue, on the pay issue, we see in far too many countries where nursing is the average nursing wage is below the average wage for the economy. I was go back to my days in the UK when I used to get the tube in London every day to go to and from work. And when I left the UK, tube train drivers were earning significantly more than a ward sister. Tube trains are a hugely important job, safety critical, and not a competition with them, and I'm not underplaying at all their skill. But you look at the job of a ward sister: 30 acutely ill patients, short length of stay, so that the complexity of what they're dealing with. They've got a team of staff, the equipment, the drugs that they're having to use and to be competent in today, way more advanced than it was even 10 or 15 years ago as well. Again, any other sector, I think, would say these middle managers, they are absolutely probably the most critical part of our workforce, because that level of nurse is responsible for, it sits at a threshold. They're looking down and have the oversight over safety and quality for customers. I know patients, we don't like to call patients, but if I take that analogy, they are absolutely the people who will set the bar, the quality and the safety threshold for people who are effectively customers of healthcare. And they are then the key people who are reporting upwards to those who are making strategic decisions. And other industries I see really recognizing and focusing on that level of management in their health system. In a way, this is not about all health systems don't do this, but far too many don't recognize that enough. And again, I think you can, when you unpick some of the history for all of that, you can see a lot of the deep-rooted historical gender issues that are at play as well.
Absolutely embedded in all of that. So it's a work in progress for sure. So much of what you're talking about, and it goes back to what I said in the beginning, the call to invest. Some of that, obviously, there's a cost tied to, but investing, if I'm a health system, I'm an employer of nurses, that investment it starts with understanding the impact of that work every day on those nurses. Because I mentioned earlier, I was impressed by the number of times that you guys are urging people to do impact assessments. If you're not investing in that first, and not just with COVID or with the pandemic impact, but this should be an ongoing assessment that health systems are doing. What is the impact of workflow? What is the impact of workload? And then how do we address that and lean in and invest in ways that keep our nurses thriving at the bedside? I can't imagine that there would be any more important investment for a health system to make, really. So I appreciate that you've jumped in on those. Let's pivot real quickly because we only have a few minutes left, but I'd love to talk about the initiative, the collaboration that we're embarking on, CGF&S with ICN, launching a new collaborative coming up, a center to focus on global nurse workforce research and analysis. I think we'll be rolling that out here in the next few months. What were the defined objectives of that initiative, and what do you hope the center will focus on in the immediate future, the outcomes you'd like to see emerge from the work of this group?
Really excited about the centre and the next stage of our collaboration with CGFNS. We've had a great history together as organisations of doing things which make an impact, and I am confident that this next initiative absolutely has that potential. Its starting point really is from a place of saying, do we have a central repository that pulls together the latest evidence and research that has been undertaken in relation to the effectiveness of nurses, nursing roles, and nursing interventions? We'd love to have more research, but often we're from ICN looking around for the latest research and where to find it, and spending some time to try and locate it. There's not necessarily an easy way for it to be brought together for people to be able to find and to look at, but to pull from it the evidence which will help to inform and drive the agenda that we have just been talking about. I often have great privilege of visiting quite a lot of our associations and attending events that they put on, and will sit and listen to somebody who thinks that they have had a relatively small-scale project within their health system that may have looked at a whole range. It may have looked at the flow of patients. It may have looked at aging populations. It may have looked at palliative and terminal care. It may look at effective health education, health prevention initiatives as well. And the nuggets within the research that they have done about what works in clinical practice, but then what needs to be done in terms of policy to support that clinical practice, to roll it, to support it, to develop it, to roll it out, to scale it out as well. So we want to try and pull together. We want to create a centre, which, as I say, is a repository, unashamedly in the first instance focused on collecting current, up-to-date nursing research. It doesn't have to exclusively be nursing research by nurses. It may be others who've done that as well, but speaks to some of these big issues about addressing the big global agenda. I think what the centre can then do is not only to collect it, but we can then promote it, and we can put it in our advocacy, and we can use it. To put that into joint reports that we might do, into International Nurses Day, to package it as briefings that can be given to associations and nurse leaders in countries to help to make the case, because we know WHO is absolutely an evidence-driven organization, and to make an impact at WHO at the global level within the global institutions, just because ICN or a prominent nurse leader thinks it is a good idea isn't going to cut it. You need the evidence to do that. You need the evidence in country as well, but then you're also hitting the complexity around political priorities and decision making as well. And as we've alluded to before, as important as the evidence is, the evidence ain't necessarily going to always get you over the line when you're dealing with those sorts of political issues. But it will at least get you a foot in the door, perhaps a door wide open, a meeting, a commitment to do more work, to put nursing on the agenda as well. So it's about it's not about just collecting evidence for evidence sake. It's about collecting the evidence to drive policy development, policy influence, political advocacy as well. And it may be also within all of that, Lea, that we then say, this is fascinating that we've got, look at all of this stuff that's come forward around advanced practice roles and primary care, but has anybody mentioned mental health, learning disabilities, or another aspect of care? So it may also expose some of those healthcare needs and services which we know are often overlooked.
Yeah, or more research is needed, or
Yeah,
more effort
yeah.
and resources needed. Just the synthesis of all that data coming together under a center like that, I think could be powerful. I mean, obviously one, like you said, you go to a conference and there's something powerful being done rather in isolation in one space. But if you stitch that together with other similar research within a center that has the resources to aggregate that, could be very powerful. We're excited to be a part of it, I know, and love that we're stepping out with ICN to do that. I don't know that we have a ton of time left, but I did want to give you a chance to talk about your Nurses for Peace campaign, because we didn't touch on necessarily nurse safety. I think you mentioned it once or twice earlier, but it is certainly another issue, keeping nurses safe. We hear increasingly around safety issues for nurses, just even in frontline bedside care, where mental health challenges are concerned, and keeping nurses safe. But even more so, I think, where you guys are focused on where nurses are positioned around, geopolitical conflicts and war zones and natural disaster response. And those are some, we're seeing a lot of that now in the U.S. with flooding and distribution of resources. How is your Nurses for Peace campaign looking at the challenge of keeping nurses safe in those environments? And what does the campaign aim to do about that? Can you touch on that just briefly?
Yeah, for sure. This is, as I mentioned earlier, this feels as though it's grown in importance to ICN very significantly in the last couple of years. It's always been part of ICN's mandate to provide humanitarian and disaster relief and support, but we are seeing an increasing conflicts around the world that is shocking, and we're all aware of exactly where some of the conflicts hotspots are as at the current time. But what we have seen as well over the last 3 years is a continual rise in the numbers of healthcare workers who have died whilst going about their job and delivering care in conflict zones. Remember, this comes on the back of our experience doing COVID. As I said, we did a lot of advocacy over the course of COVID, and there was a moment where I think that we realized that we'd broken through a little bit in terms of grabbing people's attentions globally and from the media, but it was when we said that the numbers of nurses died as a result of contracting COVID, we believe had exceeded the numbers who died in the First and Second World Wars. None of us at ICN, none of us in the global community, I could never have imagined that I'd come and work for the organization and be spending my time talking about, and collecting data on colleagues who had fallen as a result of going about their work. But this is the reality. We think that there's these data is always difficult to come by. Numbers that we do get contested. The reporting isn't great, but currently, as I speak to you today, we think there's over 1,000 nurses who've died in the last couple of years, nurses and healthcare workers who've died whilst working in conflict zones. Now, remember that there is international humanitarian law to protect people and healthcare and health facilities who are providing healthcare in those situations. And when we first start to see reports of deaths, then people might think, it's a war and accidents happen. But what's been hugely concerning to us as we've reported, monitored and spoken to nurses in all of these places over recent months and years is their sense that it's deliberate. There's a deliberate targeting of healthcare facilities as part of military strategy, and the law, the international humanitarian law, there are provisions that you can attack a healthcare facility if it's being used as an ammunitions center, or it's where soldiers and equipment and rockets and things are being
as
stored.
Part of a military strategy.
Absolutely. Yeah. So right. if that is the case, then the humanitarian law says that look, then it may be acceptable to attack that position, but you should then provide evidence of that. You should provide warnings as well. So we just do not see the protection, the enforcement of international humanitarian law, which raises these huge issues of risks and safety for nurses and healthcare workers. And these are our people. These are our professionals. And we are not. And this is difficult as well, Lea, because we're not taking a political side on this. In the same way that nurses care for people based on their need, not on their colour, their creed, their religion, their nationality. And our starting point with access to healthcare in conflict zones is that it's a humanitarian principle that you should be able to access healthcare if you have a health need, regardless of who you are. So when that isn't happening, as well as the attacks, the loss of our own colleagues, I think there's also a bigger principle about, are we losing some of the core humanity in terms of how we're living our lives, how people are interacting with each other, how different groups and parties are responding and interacting. And now that can all sound worthier than thou as well, and we don't mean to do that, but we do it for the reasons that I've said about. It's about health need, it's about the protection of healthcare workers, but we also do it because when we first created Nurses for Peace, which is our banner for the humanitarian work that we do, honestly, Lea, we were really taken back about the outpouring from nurses around the world to support that initiative. I think the pandemic, global events, we're all connected. We see it much more than we ever did. We know that we're global nurses living in a global village. And when we said shortly after the invasion of Ukraine, if nurses want to support ICN to support nurses in Ukraine, this wave of desire for nurses in other parts of the world to say, I want to try and do something to help. And if ICN can provide almost like a nurse-to-nurse support, we know that you're not trying to be ICRC, you're just trying to provide some support, financial support to nurses who are colleagues of mine. I talked to some nurses who said, and I had this, it was a reflection that I had as well, and I thought, can I just imagine I'm there doing my job one day, and the next day I'm in a war zone and there's bullets and bombs and shells coming in, and I stay at the health facility. I don't go home. I stay at the health facility to look after it, and I keep them. Can I possibly imagine doing that? But that's what our colleagues in these other places were doing. So I think there was this ethereal connection that we identify. We didn't identify it, but we provided a means for people to. What do we all talk about during the pandemic and now as well about solidarity? Well, that was at the heart of it, about just showing support, care, and compassion for people who are part of your profession, and that work.
And it's a non-political issue.
Yeah.
It's a humanitarian issue that we should all be advocating for, and we're certainly glad that you guys are standing at the front line of that and have been able to influence that. I imagine that is. It's hard to get that enforced in a war zone area. That has to be an uphill battle. It seems to the average reasonable person that these boundaries should be somewhat sacred, but we're talking about political conflicts that might make it hard to figure out who the enforcing parties would be and how you can disrupt that, keep those things from happening. So I know it's a tough issue, but I appreciate you touching on it because I think it's valuable, and I know our audience our listening audience would be very glad to know that it's going on. That brings us to the end of our time, and I just want to thank you so much. It's been a wonderful conversation. You are just a font of information and knowledge and wisdom in this space, and I know I speak for many in this profession who are certainly glad to have you leading these initiatives and passionate about them, along with Pam and others at ICN who are really such a driving force. Thank you for being here today. I don't know if there's anything you wanted to say to wrap up, any final thoughts, but
don't offer me that opportunity, because we'll go on again. Listen, all I would say, we are at ICN. We're just simply a tool or a vehicle through which we can gather together the power, the passion, the courage, the enthusiasm, the commitment, the expertise of global nurses, and through their nursing associations as well. So whenever there's work that we do which we feel perhaps makes an impact, and that's really important to make an impact and to make a difference. It doesn't come from the ICN name or logo or the small number of people who people might associate with, or they work for ICN or they're on the board of ICN. It comes as a result of being able to pull together the power of the profession and of our associations as well. And that's what we need to. That's what we always need to be so in close contact, talking, listening, understanding what our colleagues are going through, working out ourselves. What is it that because as soon as we have different voices and different messages, that can undermine our case as well. So how do we make the biggest impact and the biggest progression, the biggest move forward? Because it's about global health. It's about improving health global ultimately.
I point to nursing not only as a profession that I think, as you said earlier, is one of the best in the world, if not the best, just the impact. But also, I look to the nursing profession as a really great example of a profession that has fought well to advance itself, its value and its impact, and where others may struggle to do that. And I do think it comes down to what you just said there, Howard, the power of collective voice of those associations who come together and figure out how to advance that message together in a unified way. And I think it's done wonders for nursing. Still, obviously great work to do, but I've watched the nursing profession for 35 years. Especially, obviously domestically here in the U.S., just really advocate for itself well, very powerfully. So kudos to all of you that have done that. Thank you so much for being here. This has been a great conversation. I hope to have you back. We'll have to connect, next year and see if we can get an update, especially when the report comes out. We'd love to share some of the outcomes of the report that you're working on now.
And if you can make it to Congress, 9th to the 13th of June, Helsinki, Finland, 2025. Yep. You and anybody who's listening.
I will definitely be there.
Really
CGFNS will definitely be in Helsinki. Yeah. We are already making plans and working with your team on showing up strong there. So we appreciate you. And I just want to say thank you guys to our audience for joining today. Tune in for our next episode coming up soon. Thanks for being here. That's it for this episode of Care Anywhere. Thanks for joining us. We hope you'll tune in for future episodes where we will continue these powerful discussions about our global health workforce. If you missed any episodes, you can find them at cgfns.org/podcast or by subscribing to our channel on your favorite podcast platform. Just look for our podcast logo or search for Care Anywhere to find us. Thanks again, and we'll see you next time.